So today I'm going to be solving some MCQs question. So I'm going to be reading aloud so you guys can write it down or try to solve it along with me. So I'll be doing at least 10 of them. So let's get started. 65-year-old man underwent a Hartmann procedure for the diverticulosis yesterday morning. The next day, the nurse notifies you that the patient's temperature is 38.1 on examination. His pulse is 94, blood pressure is 135 over 80, and respiratory rate is 16. Lung auscultation reveals fine basal crackles that clear with the coughing. His abdomen is soft and mildly tender around the incision. His pain is well controlled with a morphine injection. What is your leading diagnosis at this point? Select only one. So first is hyperthyroidism. That is not. And then is intra-abdominal infection. That is not possible as well because there is no temperature. Inflammatory stimulus of surgery, no temperature. Again, urinary tract infection, no temperature. Myocardial infarction, there is no BP drop or BP increase, and there is no pulse change. So then comes the pancreatitis, which is quite impossible. Then comes the pneumonia. So with the pneumonia, this shows that the fine basal crackles that clear with the coughing. More than pneumonia, I'm thinking of atelectasis, but there is no option of atelectasis, so I'm going to go with pneumonia. So let's see. Then comes the next question. Then it says, which of the following investigations will you initiate? Select up to 2. Wound infection, CT scan of the abdomen with the oral and intravenous contrast, CT scan of the abdomen with the oral contrast, cortisol level, creatinine, Doppler ultrasound of the lower extremities, no investigations, and electrocardiography, troponin level, amylase, blood pressure, blood culture, chest radiograph, and urine culture and sensitivity. So I'm going to go with the chest radiograph. Yeah, kind of that. Diverticulosis, nurse. Yep, that's what I'm thinking right now. So it says we don't need to do any investigation. So the first thing is the answer is inflammatory stimulus of the surgery. And why? Fever is common in the first few days after the major surgery. So there was fever like 38. I didn't notice that. I thought it's 37. Anyhow, this is 38, so 100.4 at the threshold. Although this can be hospital or the unit specific, most post-operative fever is basically inflammatory stimulus of the tissue damage and the exposure to the foreign body that occurs during surgery. Then comes, what was the next one? I didn't take the picture. So I'm going to be taking the picture. Then comes the next one, and the next one is, which of the following investigation would you like to initiate? And then comes the, okay. So now I'm going to be moving on to the next one. The next one is, a 27-year-old woman presents to your office asking for birth control. She is in a new relationship and has never been pregnant. She started menstruating at the age 13. Menses occur. So 13, and the menses occur every 33 days and consist of 2 to 3 days of heavy bleeding and highlight bleeding and no cramping. She has migraines and without aura or the focal symptoms once every 3 months, but no other medical problems. Physical examination, family history is non-contributory. She does not use tobacco, alcohol, or illicit drug, and blood pressure is 120 over 80. Pulse is basically 68, and BMI is 23 kg per meter square. And then the rest of the physical examination is unremarkable. Sexually transmitted infection screening is performed and urinary test, pregnancy test came out negative. Which of the following contraceptives will you suggest? Select up to 2. So she is 27, asking for birth control, new relationship, never been pregnant, menstruating, which is going quite normal. She has migraines without aura. So migraine with aura, we don't give COCPs, but she is migraine without aura. That is like relative contraindication for that. Or focal symptoms like without auras or focal symptom once every 3 months, but no other medical condition. And then she does not use tobacco, alcohol, no sexually transmitted infection. Then what we can do here is intrauterine contraceptive device with the progesterone, combined oral contraceptives, and intramuscular progesterone, condoms, and contraceptive patch, diaphragm alone, and diaphragm with a contraceptive gel or foam, rhythm, method, sponge, tubal ligation, gonadotropin releasing hormone analog, abstinence, cervical cap, morning after contraceptive method, and progesterone, oral, only oral contraceptive. So she has a migraine with aura, so we are not going to give COCPs. She's in a new relationship and never been pregnant, so we can suggest intrauterine device like Medina IUS. So I think I'm gonna go with this one. Let's see, it says two methods, but exactly we can suggest for the condoms as well, asking for birth control. The okay, it's always the answer is one. So light bleeding, right? So she doesn't have a problem of heavy bleeding as well. Not sure about this. Which of the following contraceptives method will you suggest? Select up to two. Let's do. So they said one should be like select up to two, right? So I don't know why they said this. So we can give COCPs, intramuscular progesterone every 3 months, intrauterine device with the progesterone, and contraceptive patch as well. So we shouldn't be offering condoms. Other than that, we can give all the 4 methods. So women designing contraception should be counseled on the entire spectrum of the effective. So you can just take the picture. They said you can take all this. So we can just give as aura or focal. So this is if the patient gets an aura. So she doesn't have an aura. That's why we were giving COCPs. And what about the next? Let's move on to the next one. Then comes the fifth one. A 4-year-old girl was brought by her parents to the emergency department because of the respiratory difficulty. She is normal in the good health, and about 2 hours ago she started coughing and having trouble breathing. She has never had difficulty breathing before. So on physical examination, the child appears extremely tired while sitting up. Her breathing is labored and her lips are cyanotic. There is slightly intercostal indrawing and her respiratory rate is 25. On auscultation of the chest, there are areas of reduced air entry and the diffuse respiratory wheeze. Which of the following is completing your initial evaluation and treatment of this patient? Select up to 4. So what are we going to do is, she's 4-year-old with emergency and then respiratory difficulty. She's good health. 2 hours ago she started coughing, having trouble breathing. She never had difficult breathing before. So, and she's extremely tired while sitting up. So she's sitting up, right? Her breathing is labored and her lips are cyanotic. So basically she has a problem with that. So we can think of asthma, right? And we can think of epiglottitis, we can think of croup, we can think of acute bacterial tracheitis. But she's slightly intercostal drying. Her temperature respiratory rate is 25. That is quite normal. And on auscultation of the chest, there are areas of reduced air entry and diffuse expiratory cracks. So we can think of bronchiolitis as well. So we are doing to do is cardiac examination. Do we need to do cardiac examination since she is cyanotic and lips but the breathing is labored? Otherwise she's okay, she's having respiratory distress. So we're not going to start with any antibiotic. Check child's rectal temperature. Do we need to check the temperature? I think we need to check the temperature, so I'm going to go with this one. Checks radiograph. Yes, we can do with that. Obtain intravenous assess soft tissue radiograph of the neck and complete blood count. Why we're doing that? Cricothyroidotomy, no endotracheal intubation. I mean, she is little sinus, but there is no like, we need to examine the ear, nose and throat and examine for the knuckle rigidity. No. Administer oxygen. No. Bag, valve, mask ventilation, blood gases, racemic, epinephrine and nebulize salbutamol. Shouldn't we be doing like initial evaluation, right? Coughing and having trouble breathing. She never had a difficulty breathing before. So I'm thinking of acute epiglottitis. I'm not sure if it's the correct one, so I'm going to go along with that. So we're checking for the temperature. chest radiograph, uh, ear, nose, and throat examination. I don't think so. We do in acute epiglottitis. We don't do throat examination. So what I'm gonna be giving here is racemic epinephrine. More than that, I'll go with the endotracheal intubation. Since the respiratory rate is going down, like 25, and there is a slight intercostal drying. Okay. Let's suppose if these are the answers. Cardiac examination, I know that should be okay too. CBC, do we need to do that? Chest radiograph. More than chest radiograph, I go with the neck radiograph. There is no neck radiograph option. Soft tissue radiograph of the neck. There you go. But she doesn't have a problem with the neck. Okay, so we're gonna go with either chest radiograph or the soft tissues radiograph of the neck. So should we go with the neck? Like she said, there is on auscultation, there are areas of reduced air entry and diffuse expiratory wheeze, right? So expiratory wheeze, like diffuse air entry is reduced, right? So we're gonna go for the chest radiograph to see if there is any problem with bronchiolitis or something. I'm just not gonna go with that. And then we can go with the oxygen. Should we give oxygen? No, actually I'll go with this one. Meanwhile, I think I'm gonna go with this one, right? Salbutamol. Should we give salbutamol? I mean, we can think of asthma, right? So we can go with that. Kind of making sense. Let's see. Actually, I was wrong. So they said it's gonna be, the answer is administer oxygen and nebulize salbutamol. As I was thinking, the answer is acute epiglottitis. So the answer is basically administer the answer. Okay, let's take it picture. Let's move on to the next one. So this is the question of basically acute epiglottitis. Okay, since already done 5 questions, so we're gonna go with the one more. A 34-year-old man was brought by the emergency department with multiple stab wound in the right chest and the upper abdomen. On examination, his airway is clear, but his trachea has been deviated to the left and jugular veins are distended bilaterally. He has an absent breath sounds and dull percussion on the right side. So his breaths are shallow at 30 per minute. There are 2 penetrating wounds at the lower aspect of the right anterior chest wall and 3 wounds at the upper right abdomen. Vital signs are as follows. Blood pressure is basically 70-50, which is dropped, and the heart rate is very high, like 150. Temperature is basically normal. What are the most likely causes of this patient's presentation? So where this wound is, 2 penetrating wounds to the lower aspect of the right anterior chest wall. So I guess there is a lever, and 3 wounds of the upper right abdomen. Okay, so both draws towards the lever. That's what I'm thinking right now. There are 2 penetrating wounds. Okay, so what are we going to do with that? 2 penetrating wounds. Okay, what was that about? 2 penetrating wounds. 2 penetrating wounds. So flail chest, no. Hemophilia, no. Hemophilia. Okay, and then renal contusion. More than renal contusion, it says the right. Okay, we can think of that. Subscapular hematoma of the spleen. So spleen is on the left side, it's the wound is on the right side. Hemodilution, no. Hemoperitoneum, I don't think so. Hemothorax, no, I don't think so. It says that there is basically trachea is deviated, so we could think of that. And jugular veins are distended, so cardiac tamponade. Why not cardiac tamponade? And he has absent breath sounds and dull percussion, so yeah, we can think of hemothorax, right? And then lacerated diaphragm, lacerated thoracic aorta, cardiac contusion, and cardiac tamponade. It says cardiac tamponade, so we can think of cardiac tamponade, but it has doesn't have a high JVP, right? So that's what I'm not thinking of that way. Okay, let's move to the next one. And then dehydration, no. Lung contusion, no. Mediastinal hematoma, pneumothorax, and pulmonary embolism. Pulmonary embolism doesn't cause this. Pneumothorax. So more than pneumothorax is more like dull percussion, right? So we're not gonna go with that. Effusion is more like effusion. Absent breath sounds. I'm just gonna go with this one, this hemothorax. You can think of other thing as well. Fly chest, no, I don't think so. I can think of this. Okay, so they said you have to select up to 3 and then we choose one. So it says hemoperitoneum and pneumothorax as well. Okay, so those were the 3 answers. I hope I had taken the screenshot. Okay, since there is a upper abdomen wounds and then upper chest wounds, so we have to think of pneumothorax, hemothorax and hemoperitoneum. Okay, let's forget it and move on to the next one. Okay, then is 7th. A 53-year-old woman scheduled for an elective cholecystectomy. Her medical history is significant for hypertension, diabetes, for which she was taking enalapril and metformin. She is otherwise in excellent health. Which of the following will you include as a part of her paranesthetic workup? Select up to 5. So we're gonna go do barium enema, no. Cardiology consultation, right? She is having hypertension. More than that, I will go with just ECG, right? Electrocardiography. Okay, and then says chest radiograph. Why we're gonna go chest radiograph? She is having hypertension and then diabetes, right? So tonometry, she is having elective cholecystectomy. No, we cannot do type and cross match for the 2-patch unit. Exercise stress test, right? We can do that, but she is otherwise in excellent health, right? Glucose tolerance test, right? Why not? Abdominal radiographs review before doing cholecystectomy. We can do ultrasound more than radiograph. History and physical examination, very important. And then pre-operative blood sugar, and glucose tolerance, we should do both of them anyway. This is select up to 5. Cardiology consultation, why we need to cardiology consultation? Tonometry, no. Chest radiograph, no. I'm not gonna go with these ones, but I can go with this. So we can do pre-operative blood sugar or glucose tolerance. No, not you need to do that. PTT and PTT, I don't think so we need to do that anyways. So let's move to the next one. Next is basically the patient has been extubated and present in the recovery room. She is basically dyspnea with the oxygen saturation of 89 with 21% oxygen concentration by mass. She is spontaneously breathing at 22 breath per minute, and chest auscultation reveals crackles and rhonchi on the right lower lobe. So as what? As well as the occasional wheeze throughout. Which of the following is the most likely that would explain this patient's distress? Select up to 3. Patient distress. What would be the cause? Oxygen saturation is 89 and 21% oxygen saturation. She's spontaneously breathing 22 breath per minute, and chest auscultation reveals crackles and rhonchi at the right lower lobe, as well as the occasional wheeze throughout. So what could be the cause? Sorry. Bronchitis, diabetic ketoacidosis, hyperglycemia, tension pneumothorax, hypoglycemic reaction, intraperitoneal hemorrhage, laryngospasm, myocardial infarction, pulmonary edema, anaphylaxis, aspiration, pulmonary embolism, and spontaneous pneumothorax. Spontaneous breathing, and then chest auscultate reveals crackles and rhonchi in the right lower lobe. Tension pneumothorax doesn't look like that. Hypoglycemia, no. Intraperitoneal hemorrhage, laryngospasm. Okay, and then edema. Like there is reveals crackles and rhonchi at the lower bowl, so we can think of edema. More than enough anaphylaxis, I would go with the aspiration. Okay, aspiration. We can think of aspiration. Like let's just go with this one. Embolism doesn't look like this way, is it? As well, okay, wheezing throughout, spontaneous pneumothorax, no. Edema, hypoglycemic reaction, tension pneumothorax, hypoglycemia. Oh god, okay, I'm just gonna go with these 2. Okay, so the next is the same patient is now extubated and in the recovery room. She is now noted to be stridor tachypneic, and she has a oxygen is same like 89 to 28%. Then auscultation reveals decreased air entry throughout. Which of the following diagnosis best explains the patient distress? Select up to 2. Oh my goodness. Air entry throughout. So auscultation reveals decreased air entry. Okay. Bronchitis. Why not bronchitis? We can keep on thinking of this thing. Then diabetic ketoacidosis, hyperglycemia, tension, pneumothorax, hypoglycemia, intraperitoneal hemorrhage, laryngospasm. It could be one of the laryngospasm cause. Okay, and then aspiration. What could be aspiration? Okay, so the first one is basically correct except for abdominal ultrasound, because it's an elective one, right? So we don't need to take the ultrasound. Okay, that makes sense. So I'm gonna be taking a picture of this one here. Okay, so now moving on to the second one. The answer is basically aspiration, not the edema. So we choose the two one, but the answer was aspiration, which leads to the laryngospasm or bronchospasm or aspiration pneumonia. Okay, then comes the third one, which is basically aspiration leading to laryngospasm. Okay, so I guess that's about it. I'm not going to be doing more of them. I'm going to start reading, and I'll definitely try to record it and put it for you guys to review. Thank you so much for joining me.